this session. We are delighted to have two experts from Israel. Welcome to both of you, as well as to Dr. Samita Ginige from our own epidemiology unit. It's my pleasure now to briefly introduce the two speakers from Israel. Dr. Asher Samon is a clinical oncologist by training and holds the rank of Lieutenant Colonel in the military, MD, PhD, MDA, and he's the head of international relations at the Israeli Ministry of Health. Prior to joining the ministry, Dr. Samon served as deputy director of Hadassah Medical Center and of Barzilai Medical Center. During COVID-19 crisis, he also had been responsible for interministerial coordination in the areas of travel, borders, and national security. He served as the ministry liaison with the National Security Council and is a member of the National Health Council and the OECD Health Bureau. Welcome to you, Asher. And then I have the pleasure of introducing Mr. Adam Cutler, who is the Deputy Division Director for International Relations and Media at the Ministry of Health in Israel. Prior to joining the ministry, Adam served as a member of the Israel's National Security Council under the last three prime ministers. Through his work at the ministry, Adam works to strengthen partnerships and share Israeli expertise, as well as bring global expertise for the improvement of the Israeli health system. So what we hope to do is first to listen to the two experts from Israel, and after which our own Dr. Samita Ginige, who is a deputy epidemiologist at the epidemiology unit, Ministry of Health in Sri Lanka, and he will also speak and give a response. He's mainly responsible for the national level coordination of the COVID surveillance activities and the implementation of the COVID vaccination program. So it's my pleasure now to invite you, Dr. Asher and Adam, to start these sessions. Thank you.
Thank you very much. Pleasure for me attending this morning, actually, this afternoon for you, this important session. I would like to open with a brief description of what was done in Israel and give you some clues about how did we manage with these challenges and how things look now. And then I'll be very happy to take some questions. I'll start just giving a general background, and then I would ask my colleague Adam Cutler to join and to elaborate a bit about what are we doing regarding public diplomacy and media campaign in order to gain confidence and collaboration from the population. So as you may know, Israel is a country just above 22,000 square kilometers, like 1/3 of Sri Lanka. Our population size is 9.25 million residents. We are a relatively young society, the youngest of OECD, with a very high fertility rate of above 3. And although life expectancy is very high in Israel, the portions of 65 and above is below 12%. Everybody in Israel is covered under a universal public health law, which was legislated in 1994 and covers all citizen residents, even temporary residents, which lives in Israel. You are entitled to choose one of 4 HMOs. The HMOs are not anymore insurers, but rather service suppliers. On behalf of the government, you pay a tax, a health tax of 5%. And that will cover roughly 50% of the national expense. The other 50% is paid directly from the government budget. It's important to mention this point because the HMO had a crucial role in the successful campaign of vaccination, as more than 90% of all vaccination occurred in or through HMOs. These HMOs are spread nationwide, so you are entitled to choose any of them and you are entitled to switch between them twice a year. And they are obliged to provide services in due time and in due distance in any spot in the country. We have a good history of pediatric vaccination. It is above 97% compliance. So as where we are now, Israel gave till yesterday more than 9.5 million doses of vaccine, which seems to be more doses than the size of the population. More than or roughly 42% already of the population already had been vaccinated twice and are entitled to receive a vaccination certificate. And what is mostly now is missing are children that we could not that we can't vaccinate yet, as we don't have the data to support vaccination below the age of 16. And we are still focusing in 1-point-something million Israelis that from any type or any reason opt not to be vaccinated yet due to or negligence or lack of time or access or some belief in anti-vax propaganda against vaccination. So I think in that sense, we are now the nation with the highest rates of being vaccinated, as I could say that above 80% of all adult population is either vaccinated or recovered. And we are now starting to see a drop in COVID numbers. So you could see here numbers in general. It is quite clear that 70 and above is 90-something% coverage. Between 50 to 60, we are around 90% coverage. Between 16 and 50, we have a whole variety, and we are campaigning now in order to bring to the vaccination site young people, young adults, and adolescents, which are 16 to 18. Just to give you some data regarding COVID-19 in Israel, till now, 7.5% of the population was found positive by PCR of encountering COVID-19. And although we have a comprehensive system, we have lost the life of more than 6,000 Israelis during this pandemic. In comparison to European countries or North America, these numbers are very reasonable, even good. But in our own personal ethos, we are very much unhappy with the fact that we lost so many lives. We are now at the end of the third wave, which is ending these days. We are out of our last national lockdown 3.5 weeks ago, and we are under I would say a rolling multi-phases opening strategy of the economy and the society in the country. We have just passed 3 phases of opening, and at this, as it is now, many venues, including restaurants, swimming pools, gyms, cultural venues, concerts are open for people which are holding the green tag, meaning or they were fully vaccinated or had recovered. I guess Adam Cutler would elaborate on this point a bit. Anyhow, looking into our operation, it was clear for us that we needed to have a quick, as fast as possible operation in order to reduce morbidity and mortality and allow our society back to normal life. It should be simple, and as you keep it simple, it is more effective. And due to that, we have a national prioritization vaccination committee who had decided to vaccinate from the first day everybody which is 60 and above, with no subgrouping of risks. So from the first day, we were vaccinating people 60 and above, medical personnel, and first responders. And then on a weekly basis, we had dropped the age by 5 years, average 5 years every week. So from 60 went to 55, then to 50, then to 45, then to 40. and then to 35 and open it completely for everybody. There was a big issue whether we should first vaccinate first responders. There was some debate, but at the end we did use first responders as a kind of a standby group where we could call a local police station or fire brigade and tell them, look, this and that nearby point, there are some extra 100 doses, please go now and be vaccinated. Another issue is that the whole operation is paperless, and we have a centralized IT system which is running, controlling, and collecting data regarding the whole operation, including a proper national tracking, side effects, and adverse events related to these vaccines. Media was a major tool from the beginning, and actually we did start to prepare the public few weeks before, and we had tackled many issues which Adam would elaborate, both in the general public but also for specific communities. So that's the way that we have done it. Some challenges. We are vaccinating predominantly using Pfizer vaccines. We do have some Moderna vaccines as well. We did not receive any AstraZeneca yet, and I'm not sure that we are going to use. But more than 95% of all vaccines which we had were manufactured by Pfizer. And the main challenge, of course, as you know, is ultra cold storage requirement of Pfizer, which was -80, although now it was just lately reduced to -20 for 2 weeks. But if you want to hold it for the full length of its effectiveness dates, you need to hold it at -80. When you take it out, when you take a vial out of the -80 ultra cold storage, you have a short shelf life where you need to hold it in around +2 to +8, and then you must use it by 120 hours. This is a big limitation, make you to have to plan very really meticulously exactly how are you going to vaccinate, when and where. Another main problem, which is even a more complicated issue, is I would say the lack of stability of these messenger RNA liposomal solutions. Talking both regarding regarding Pfizer and Moderna, which are extremely sensitive to vibration shock. And we got this instruction that you are allowed to take it out of the freeze and you have to send it to the endpoint, and you are not allowed to re-ship it anywhere else. So when it was sent out to a certain point, at that point you need to use it at full extent, and you can't just take the leftover and send it somewhere else. Unknown demand is an issue. Adam would elaborate about it. We have decided to pre-register all vaccine individuals. So you had to pre-register, and I would say a word about it in a minute. If you would come just on a kind of a standby chance, there was a good chance that you'll be vaccinated, but there was no guarantee. So if there were no leftover doses and it was fully booked and you came without registration, you may be turned back and asked to register properly and come in another day. Regarding unclear supply, it was unclear for us how and when and in which accuracy of time Pfizer is going to supply us. It was found to be very reliable, and we were always supplied on time. But due to that, I would say at the beginning of this campaign, there was a kind of a psychological phenomena of demand and supply. And the idea that you should come today because maybe tomorrow no vaccines will be left did encourage many Israelis to come sooner rather than later. A main point of our operation was the fact that everything was run centrally by our National COVID-19 Operational Center. This operational center is run by the Ministry of Health, but many other agencies, governmental agencies and offices are represented. So Ministry of Finance, Ministry of Foreign Affairs, Ministry of Internal Security, Ministry of Defense, all of them were represented. The civil police, the military was represented by the Home Front Command, which had a main donation, actually contribution, to the whole fight against COVID-19, including the vaccination process. Ambulance services, HMO, hospitals, all of them were around that table, which is still operating 7 days a week and is running the national effort against this pandemic. And so in that point, I would say that the vaccination operation was centrally led and planned, and each dose which was given was planned a week in advance in a very precise way. As we are dealing with Pfizer, we decided to have only one single national logistic storage center. And we have used the logistic site of Teva, our largest pharmaceutical company, and all Pfizer vaccines were stored in this site in huge fridge, which of course had to be well controlled and under all regulations. We did have a discussion, as many other countries, whether we should vaccinate as many people as possible with a single dose and give later the second dose, or should we stick to the manufacturer protocol? We did decide to stick to the manufacturer protocols, meaning that each individual who received the first dose of Pfizer would receive a second dose after 21 days, and each individual who received the first dose of Moderna would receive the second dose 28 days after. That made the necessity to secure a second dose for each individual who received the first dose, and that created some type of, I would say, issues in the beginning. And only when we were very much confident with the shipment scales of Pfizer, we were more flexible in order to reduce a bit the amount of doses which were kept for the second shot. Distribution is done by cool trucks early in the morning with a meticulous weekly planning. Each vaccination point, and we do have around 400 of them around the country, or is supplied every second day, meaning that we are expecting them to finish all doses which were supplied in 48 to 72 hours, rather to wait for the 120 maximal hours allowed. So that is a schematic way from a single central logistics center. The whole country was supplied. Needles and syringes are crucial. Some countries did not purchase enough of them, and that created major difficulties. And even if you read about Japan, which did not have the proper type of syringes, that lost the ability to draw more than 5 doses per vial, and many other countries the same. So we did plan in advance and purchase enough needles and proper syringes. Distribution I have already mentioned. We did vaccinate people in large commune areas like shopping malls, stadiums, sport arenas, where the HMOs could open large vaccination centers with large space so people could safely queue with proper physical distancing, and there was enough space for people to safely rest for 15 minutes after getting the shot before they were discharged back home. HMOs also vaccinated in community centers and primary healthcare clinics around the country. In small rural areas, we did instruct the HMOs to commune together and open mutual vaccination sites for the 4 HMOs together. And that was a great, I would say, option for us to open more commune sites to reduce potential loss of doses and to make it more accessible to all of our residents and citizens. We did also ask all public hospitals to open vaccination sites. They first had to vaccinate their medical personnel, then vaccinate their patients, and then join the national effort and vaccinate also other groups. At the same time, we have outreach using the Homefront Command and the ambulance services, more than 600 nursing homes, where we had vaccinated all aged population and the staff of these homes. We still have some problems outreaching homebound, long-term care, disabled patients, which is almost impossible to move them. Any one of them that could be confirmed, we have sent an ambulance, brought them to a closest vaccination center, and took them back home. To the ones that were impossible to do so, we are still debating what to do. We may need to wait till AstraZeneca would come sometime in a few months from now. Some lessons learned. We did open 2 types of call center. The first one was for professionals, where professional, mostly nurses and paramedics, could call in 24/7 with dilemmas, queries, questions, and diminish errors during this operation. And the second call center for the general public, where we had tackle many questions and worries, and that indeed gain or help the public confidence and reduce unnecessary visits to emergency rooms. It was evident for us that we have to cut down, to slice down the standard supply cases of Pfizer, because they do supply in cases of 960 official doses. Actually, if you could extract more than 5 doses for Pfizer, it would be for more than 1,000 patients. It is great for large location, but for small oral location, we had to send smaller amount of vaccines, and we had created these pizza slice style cases, which could deliver as little as a single dose, a single vial if needed. We did centrally trained nurses and paramedics. We decided to train the trainers, so we have trained the trainers of the HMOs and the hospitals, and they would then train the rest of the teams. A lot of the training was done through Zoom or through other remote control software. Side effect and tracking and risk management was a major issue. We have, as I have mentioned, the whole project was paperless, and we had a national software who collected all pieces of data. So if you would like to register, you would register through your HMO, by the call center, or by the internet, or through an app on your cell phone. And that registration would be sent to the central database. When you would be vaccinated, despite less if you are vaccinated in a hospital or in an HMO branch, a signal would be sent to the national registry, and another signal at the second side would be sent to your own personal electronic medical record. That would result in a text message that you would receive after getting your shot, greeting you for your first appointment and reminding you the day and the time of the second appointment. This system would collect also all side effects and adverse events, so we have a clear picture of the of the risk of developing side effects from all kinds and all levels of severity. I have to just to say in a word that we did not experience any major safety issues on what was already published by the clinical trials of Pfizer and Moderna. The only thing that we did see a bit more was kind of this transient hemiparalysis, facial hemiparalysis, is kind of a false palsy that we occasionally saw. It would usually fade by itself in a few hours. Documentation and Green Pass are an important part of the whole project because it's part of the secondary benefit for the public. And I would suggest at this point that Adam Cutler will continue to speak about public diplomacy and regarding our Green Pass policies. Adam, please.
Thank you, Dr. Salmon. I'll just speak briefly. Can we advance to the next slide? Or I can share if that's easy.
Here you are.
Okay, so we've had a focus throughout our communications with influencers and community leaders. We looked at the medical community also in this framework. So it was very important that doctors were among the first to be vaccinated, and they served as an example. We videotaped, we filmed and broadcast vaccination of our Prime Minister as patient number one to receive the vaccination, and of many other national and local leaders being vaccinated in order to reassure the public. Very important that when we defined the prioritized group, we defined it broadly, as Dr. Salmon said, 60 and up and medical personnel. That created a lot of momentum to the vaccination centers. It meant that very early on, the population knew someone, had a personal familiarity with someone who had been vaccinated, and that went a long way to reassuring the public. Our digital tools have been absolutely fantastic in this regard, taking the burden off of the patient from being, from the need to be proactive. Rather, our HMOs were able, through the integration of their clinical data system, their communication system, and their appointment booking system, to pull the patients who had been prioritized, to reach out to them via email, text message, or through the app, and ask them, even voice messages, and ask them, push one, click this link, and book your double appointment. It made it easy. It meant that the HMO could be proactive about recruiting its members. And all of this momentum created a lot of national pride and really changed the framework through which the country saw the vaccine drive as a national effort where everyone got behind. I'll talk briefly about the Green Pass program, but first I just want to mention we have had a task force for each minority community embedded within our National Emergency Operations Center. They've been critical to monitoring not only compliance with social distancing regulations, but also infection rates in these minority communities, and particularly in guiding our communications efforts, as well as advocating for additional resources where needed. This has been tremendous in every minority community is different, but in the importance of having these task forces embedded within our emergency center meant that we were able to ensure that no minority community was left behind, and that we were communicating effectively with them, even sending our minister to meet with local leaders in those communities. Now, I talked about IT and the integration for the vaccine booking, but we also have a national system for documenting the vaccination of the population. Once a vaccine is administered, it sends a message both to the patient's electronic medical file as well as to a national vaccination database that was established, which forms the backbone and the basis of our Green Pass system. Dr. Salmon, can you advance the slide? Before I get into the Green Pass system, I want to talk about how our efforts are transitioning at this stage. We've gotten those who are eager to be vaccinated, and we're now at a stage where we're reaching for those for whom vaccination is either less accessible or those who are less motivated to be vaccinated. We're reaching out to partners in order to get to these people. We're reaching out to businesses, to educational institutions, and to municipalities. And we're telling them essentially, organize us at least 100 patients, and we'll send a shipment of vaccines and clinic staff to your location, often in a mobile clinic format, and we'll vaccinate. So that gives businesses the opportunity to vaccinate their employees, to tell their employees to bring their family members in to be vaccinated. It gives municipalities a real interest in reaching out to their residents, in ensuring that that municipality remains green. and doesn't become subject to any further restrictions of social distancing. And educational institutions are also, particularly higher education, are just reopening their doors for learning and want to ensure that they don't have an outbreak. So that's been critical. If I can just have the next slide, please. Our Green Pass program is broken into two segments. One is for domestic use and one is for international use. The international document is a vaccination certificate with a secure QR code and all of the travelers' information. At this stage, it's important to note Israel is still closed for international travel for the most part. But the vision is that that will eventually enable a link between the individual's vaccination status and their passport and enable them to travel to countries which would prefer to verify that a traveler has been vaccinated. Our domestic solution is not a medical document as the vaccination certificate is, but rather preserves the patient's privacy. It's open for recovered patients up until a certain date. It's open for those holding a valid vaccination certificate, as well as in some cases, those who've recently tested negative with a PCR test. It's designed to enable us to reopen our commerce and to, in certain situations, relax the social distancing regulations in a safe manner. And it also provides a tremendous incentive, particularly for young people who are eager to get back to life and back to their social lives and business and professional lives to get vaccinated. Essentially, it allows us to reopen restaurants, gyms, pools, theaters, concerts, and sporting events in a safe manner. And it's got several components. One is an app where you can verify your status as having a green pass through the app and show it at the entrance. And there are other solutions for those who do not have smartphones, whether it's PDF printout or even the ability to call in to a hotline to verify an individual's status. All of this has come a tremendous way to motivating our population to get vaccinated, and we're continuing full steam ahead. Thank you. I don't know if we'd like to go to questions or if there are other presentations.
Yes, thank you very much. We've got another presentation from Sri Lanka. So, Samita, are you there? Samita? You have to unmute. We can't hear you. You have to unmute, Samita.
Yeah. Okay.
Yeah, okay, thank you.
So give me 1 minute to load the presentation.
Right, okay. Right, thank you very much. Thank you, Adam, and thank you, Samon, for that excellent presentations which detail your strategy which was used. While Samita is getting ready, just to ask you a question, what sort of structures did you develop new organizational structures towards control towards the vaccination program, or you use the existing Ministry of Health structures?
It was run by the COVID-19 Operational Center, which is a structure run by the Ministry of Health. But as I have mentioned before, it contains many other governmental bodies and offices. So we did not create something totally new, but under operational planning guidelines and logistic approaches, rather than using the standard offices, we had this working team. It's more than a working team. It's an operational center that contains like 20, 25 different working teams. Some of them are basically the employees of the ministry, like Adam and myself, and we do spend more than 80% of our time there. And some of them are newly recruited or temporarily recruited for a year or so in order to fight COVID-19. Many of them come from the public or private sector. Some of them come from the military. And these people have joined us as part of the operational arm during the COVID-19. And what we have done was to lease a large building near the airport, who became the national center. And we do hire these people and temporary contract for a year or a year and a half till hopefully this pandemic will be over.
Thank you very much. So now we'll have the presentation from Sri Lanka, and Samita will do the needful. Samita, over to you. Thank you.
Initially, I brief about our country situation and the outbreak situation, because we started the first case in 27th with the foreigner. Then first local case reported in the 11th of March. And during this nearly 1 year and 2 months period, we have reported 88,000 cases with 532 deaths. It means giving the case fatality rate of 0.6. And our cured rate is 97%. But time to time reported clusters at the different location with various intensities, and country was free from local cases to a nearly 2 months period from 2nd of August to the 4th of October. But after that 4th of October, we had a massive outbreak in the garment industry, and followed by one main supply chain in the fish market. That's the main national level supply chain that have a devastating effect on spreading disease to the many parts of the country. Still, we are experiencing the small clusters as a result of that major outbreak. Up to now, these total cases only 5%, 4,808 reported among imported cases among foreign returnees. But these are the few examples. If you're starting from the January last year, we started with the small cluster from the Italy returnees, because a lot of Sri Lankan returnees came in during that period. After that, some pilgrims visited in some Middle Eastern countries came with the disease, with the small outbreaks. Then some small cluster we experienced with the 21 cases with among drug addicts. Then followed by a urban slum area, we have another outbreak with total number of 83. But after that, in last April, we had a massive outbreak with 950 cases in a major naval camp in Sri Lanka, in the capital city of closer to Colombo. That have a devastating impact, and lasted nearly 2.5 months, that outbreak. Then after that, foreign returnees, because especially from the Middle Eastern countries, large number of our expatriates returned to the country during that period. They have that all of them were quarantine, subjected to institutional quarantine. And but among them, we have a significant number of cases during that period. Then followed by, we had another outbreak in drug addict rehabilitation center. That's also have reported 650 cases, lasted for nearly 2.5 months. But after that, it's a massive outbreak, which I mentioned earlier. 4th of October, we had in one of the garment industry, garment factory in the Minuangoda area, that reported nearly 3,000 cases and lasted nearly 2.5 months. Then after that is the fish market cluster. That's the largest cluster. Still, it's continuing. Up to now, it's reported nearly 77,000 cases, but it has a main supply chain at the center, and it has connected to many fishing harbors and fish markets all over the country. It have a devastating impact and the rapid spread, and reported many sub-clusters as a result of this main cluster. But if you see our epic curve, we can see before 4th of October last year, we have relatively very small clusters. We successfully control time to time, and each cluster followed by another cluster. But since October major cluster, it's lasted for many, and small dip we have observed in somewhere around the early part of December last year. But with the Christmas Eve and the New Year vacations and the other other celebrations in the Hindu celebrations, I think we have experienced another small wave in the different part of the country. But now, since February to second week of February onwards, we are experiencing a steady decline over the last two weeks period. If we analyze our demography of our reported cases, only 9.1% or less than nearly 10% of the cases are reported among above 60 category. That's was the above 60. Majority of it, mean nearly 80% of our cases are reported among 20 to 60 age group. That is the main reason we are considering when we're starting our vaccinations. We mainly concentrate on above 30 category plus above 30 as a main thing, because we need to control our transmission mainly, because reported cases among adult population is relatively very much less. Then among reported cases, 62% were asymptomatic, 38 were symptomatic. And up to now, as mentioned earlier, deaths reported among 0.6%, and patients under care currently 2.6%, and recovery rate is 97%. If you see the, but this is the number of suspected patients admitted over the period. But you can see this is the lull period. As I mentioned earlier, August to October last year, we have not a single case of local transmitted cases reported during that period. During that period, our number of suspected cases admitted to the hospitals are very low, around 50 to 80 in number. But since the massive outbreak started in the October, suspected cases admitted to the hospital with the signs and symptoms suspected of COVID steadily increased. It reached the peak in last October, December and early January. But since latter part of the January, we can see a steady decline in the suspected case of COVID-like disease admitted to the hospital. Even if you see the positive number of PCR testing and the number of positivity, we can see even with the peak of the outbreak, our number of testing in the blue line is massively increased, because earlier in the beginning of this particular outbreak, our PCR capacity was somewhere around 3,500 per day. But with need, we were able to increase it up to 18,000 per capacity, up to 18,000 per day. But still, though we have increased significantly our number of PCR testing, but our positivity number positives always somewhere around less than 500. But some on and off days we experience about 700 or 800 cases. But you can see a latter part, even though with the high number of testing, still decline pattern of the number of positive cases reported in red line. The same thing is our positivity rate. So our positivity rate somewhere fluctuate around 4 to 5% in the initial phase, but very rarely it's go up to one. So few occasions it's go up to about 5%, but in average 4 to 5% is our positivity rate. According to WHO, they recommended the country to maintaining a proportion of 10 to 1 positive for 10 tested. But throughout this period, country was able to maintain that standards. But during a non-outbreak situations, our ratio was 20 to 30 tests per 1 positive case. But especially during the massive outbreak period, December to January, it reduced up to 15 per 1. But again, with the latter part of January onwards up to February, it increased up to now 34 to 1 per 34 tests. Even is our death rate, I think that's also about reported up to now. We have experienced only this not updated up to today 532 deaths, but a massive number of deaths. I think nearly 80%, 90% of the deaths were over 60 years. 80% of the deaths were over 60 years of age. These are our responsibilities. I think we have a national level epidemiology and a COVID task force chaired by His Excellency. Then we have a national focal point at the surveillance focal point at the epidemiology unit. All the cases were reported to the epidemiology unit. We have well-established public health infrastructure for the surveillance purposes and the contact tracing. We use that well-established public health infrastructure, because district level we inform immediately. All the cases were informed to the epidemiology unit. Then within seconds we inform it to our district level regional epidemiologist, and the divisional level, each divisions have a team, public health team headed by the medical officer of health. Then they are having another category called public health inspectors. Each 10,000 population is covered with one public health inspector, because his main responsibility is to be as a team, public health team, immediately if we inform, mobilize that patient for the treatment center and quarantine all the contacts and follow up them and carry out PCR testing for contacts. Then same time, same information. The Sri Lanka is the model. I think we always use the our national intelligence system and the armed forces in the effective manner for contact tracing and the surveillance activity. Then simultaneously, we have EPID unit always inform the patient information to the national intelligence system, and they also have a parallel system. They also help to contact tracing, because we have done the extensive contact tracing, because the health level, certain contact tracing we can do, but certain things, but national intelligence system, each and every case they followed for last 14 days, all the movements and all the contacts using the modern technology, and isolate them, quarantine them, and subject them for the PCR testing. This is our testing policy. All close contacts were subjected to PCR testing immediately based on their exposure nature and the end of the quarantine period, 14 days quarantine period. Then same time, we have carried out vulnerable and high-risk community screening regular manner. Then all COVID suspected patients were supposed to admitted to the hospitals, and all of them were subjected to the PCR testing. Then in addition, all the patients with the pneumonia-like symptoms were subject to the PCR testing, and all the suspected deaths were subjected to the PCR testing. Then all the healthcare staff with unprotected exposures were tested. Then the patient from the high-risk geographical area prior to their medical procedure, then random sampling done in time to time. And other than that, we have started hospital-based sentinel site surveillance in a representative manner. All the hospital, based on their capacity, they are supposed to send minimum number of 10 to 15 samples per day for the PCR testing. Our public health strategies are, one is the extensive contact tracing, as I explained earlier. Then all close contacts were subject to the strict house quarantine or institutional quarantine. Screening of a high-risk close contacts, and both symptomatic and asymptomatic COVID positive patients were provided with institutional care. And all the patients with positive results were sent to institutional care. Then each, because our Sri Lanka having a free health service, all the even both public health and the curative care sector is totally free of charge. Then each individual positive case is investigated at the central level as well as the field level to identify the possible contacts. Regular screening of high-risk populations. All the subjects with signs and symptoms suggestive of COVID admitted to the isolation units, and hospital-based sentinel surveillance. And all the factories were asked to, large-scale factories were asked to carry out routine screening of 1% of their population weekly basis with the PCR in the high-risk areas. Then adopt lockdown strategies to identify high-risk localities time to time. Then public awareness on preventive measures, and adopted selective strategies to discourage border crossings from the high-risk areas to low-risk areas. Our enabling factors of this is the well-established public health infrastructure covering the whole country, and high standards of the curative care and the laboratory services, and free health service with equitable access, and the very strong prevention and quarantine disease ordinance. Is a 120 years old act, but still it's a very valid act and have a lot of powers to the Director General of Health Services when it comes to quarantine and prevention of diseases. The relatively high literacy rate, health-seeking behavior of the public, and the high level of government commitment, and close collaboration between the health sector and the military sector in active contact tracing and maintenance of quarantine centers, and relevant subject specialists were consulted during the key decisions, and the evidence-based decisions were done. Then other than that, when it comes to the immunization, I think first lot of vaccinations we are started with AstraZeneca, Oxford AstraZeneca vaccine produced by Serum Institute of India. We got as a donation 500 doses of vaccines on 29th of January, but 28th of January, but 29th onwards we started our vaccination program, because we have well-established immunization program through a public health infrastructure. But as a country, we have a good track record about vaccination. Say childhood vaccination for last 20 years, we are maintaining above 99% coverage. We are using the same structure for the to provide vaccination opportunities with the COVID vaccine. But all 500 vaccination, when you identified priority group as our frontline health workers, or both curative and preventive care health workers were already vaccinated in both the state sector as well as the private sector. In addition, because all the other frontline workers, especially the armed forces and the police, they're actively involved in these operational activities in contact tracing and maintaining quarantine centers, then all of them were provided with vaccine. Then other than that, all the other key institutions we have identified as economically vulnerable institutions, as well as the places where outbreak control is difficult with our experience, like harbor, main harbors, airport, and the petroleum and the power plants, and that's key centers were provided. All the workers attached to those key centers were provided with protected with vaccine. And the Western province is the worst. Nearly 63% of our cases are reported from the Western province. Because of that, all the police stations, and based on our epidemiological evidence, where we experience most of the cases, because police stations were other places we experienced a significant number of cases, then all the police stations were provided with vaccines. Then other than that, the medical students and the other nursing trainees, because they are also getting exposed to the patients, were by now totally vaccinated. In addition, country has then after that we got able to procure another 500,000 vaccine from the Serum Institute. Using that, we have started community vaccination, especially in the community vaccination mainly limited to the Western province, where 63% of our total cases are reporting. That also, considering the limited availability of the vaccine, we have identified small administrative divisions, we call GN divisions, with high to identify high risk GN divisions. We are used for parameters. One is the number of cases reported during the last 2 weeks, and the number of cases reported during the last 3 months, and the number of deaths reported, and the other social demographic environment of that places with our epidemiological experience. When we have certain places, we know by experience control is extremely difficult with the existing conditions. Based on those 4 parameters, we have identified small GN divisions and provided vaccination for the above 30 age group. But the rationale of selecting above 30, that's something different from the other global experience in other country experiences, because our objective was to, when we analyze our caseload, we have experienced nearly only 10% of our caseload is above 60 years of age. Bulk is in the economically active group. Even when you are taking the surveillance activity, we have found significant majority of those above 60 patients also got the disease from the young people living in their households, are the one carriers who take the disease into the household. Because in Sri Lanka, culturally, older people their movements are somewhat restricted. Considering those factors, we identified high risk area above 30 category. In addition, last week we got another 262,000 doses of AstraZeneca vaccine from the COVAX facility that I think we agreed to provide only to the above 60 category, but now country starting that using that 264,000 doses to vaccinate above 60 age category living in a high considering the limited availability of the vaccine, priority given for the high risk GN divisions. Up to now, country has vaccinated nearly out of 1.2 million vaccines we received. By now, country has vaccinated nearly 800,000, and out of this 800,000, nearly 100,000 given for the above 60 population. Vaccination program is going on smoothly. Thank you.
Thank you very much, Samita. Now the floor is open for discussion. Have you got any questions, Amira?
Not at the moment, Dr. Jayasinghe, so you can proceed until we get some.
Yes. Samita, now there are several lessons we can learn from the Israeli experience.
Yes.
So it's fascinating to see the differences, the way we have tackled it, because we've gone towards the younger age group, while Israel had a different strategy. So any comments on this, how you all came about this with this formula? Did you all do any modeling and decide on this, or?
We did a lot, and it would be hours of lectures. I did not touch anything related to surveillance, public response, chain cutting epidemiological investigations. A lot to say about all of that. As I was asked to focus on our vaccination operation, I did focus on that, but I have to say that Israel till now, at least by the official numbers, had more than 700,000 positive cases for just above 9 million citizens. Our testing capacity, which was only a few hundred when the pandemic started, had raised up to 150,000 a day for nationwide. We are not using this capacity. We are doing less than 100 now. We have many questions regarding how to proceed, whether to continue on with massive PCR testing, or should we now rely more on fast antigen-based tests, which we are now introducing, and at least some of these tests had been proven to be very accurate with high, both I would say good detective rate and low false positive rate. It took time. So many, at least the first types of antigen testing systems that we have tested were not so good, but now they are improving. We are still running under national clear social distancing regulation and processes. The education system did not fully open at least from the end of September. We did fully open at the beginning of September, and due to the second wave, we had shut down some of it, and classes, mostly middle classes of 7, 8, 9, and 10th grades, hardly have studied anything during the last academic year. We would try to reopen them fully after our Passover holiday. At the end of next week, we have a week holiday. After that, we will try to open them fully. Still, aviation traffic to Israel is very limited with massive restrictions. Foreign citizens can't enter Israel unless they have one of 20 criteria making them eligible to receive an entry pass to Israel. That include even, I would say, citizens of countries that do not need a visa to Israel can't enter. Israelis at this point can't fly out free of Israel unless they are vaccinated, unless they have the green tag. If you want to fly out of the country and you don't have a green tag, you must apply to a special committee and to convince that you have extraordinary circumstances that you need to travel due to that. We are still discussing how to fully open cultural life. As I have mentioned, we did open theaters and some venues using a green tag, meaning that you have to be vaccinated or recovered to enter. The whole system is still trying to understand how things are. Now, although we are so widely vaccinated, we still have, I would say, around an average of 1,000 new cases a day for the last week. The R0 is dropping down. It was 10 days ago above 1. It is now around 0.7, meaning that things are on the right track, but we still have many new patients. At that sense, I don't think that we are going to lift all restriction. We would live in an environment of restriction for at least few more months. We would see restriction in aviation traveling for a few more months. And I do hope to be able to finish our vaccination process for adults sometime at the end of April, and to be able to start vaccinating teenagers at the end of the spring, and hopefully be allowed after receiving the international clinical trials for children to be able to vaccinate children at the second half of this year. If it would be done so, and compliance would be good, I do believe that we could, at least in the context of Israel, try to become a COVID-free country sometime toward the autumn, maybe the autumn. Anyhow, I need now to leave for a national committee. So I would like to thank you all. Adam would stay for more questions, and I really wish all of us a healthy and a prosperous future. So thank you very much.
Thank you very much, Simon. Thank you. And we've actually come to the 1 hour mark. So if Adam, if you're available, and Samita, if you're available, we can go on for a few minutes more. Amira, is that okay?
I'm okay with that if they are. We have one more question. I see a raised hand by Gayatri D'Souza. If you want to pose your question, Gayatri.
Yes, doctors, thank you for your very informative presentations. My question is to Dr. Samita Ginige. Myself and most of the people I know here in Colombo have been vaccinated. We got our first dose sometime last month. And I think on that card, it says that we will be getting the second dose in either 8 weeks or 10 weeks. So how will that work? Will they contact us, or is there a specific date, or how will we get the second dose?
You're muted. Samita, you're muted.
I think everything is planned because second dose will start according to as we started our program on somewhere in the early last few days of January and the early February. Due after 8 weeks lapse, they are starting with the after New Year. They have planned to start at giving the second dose. I think based on the similar way, we will public address system we will use, and the individually also in the Grama Nildari and the public health system, they will inform you all.
Thank you very much. I think that's something I think we can certainly learn from the Israeli experience, because I think they had a very well organized sort of communication strategy. Perhaps that's an area, I suppose, which we can learn from.
Yeah.
Yeah. Shall we? Anyone else? Any other questions? So, in the absence of further questions, let me once again thank Adam Cutler and Dr. Samita Ginige for your contributions. And once again to the Pathfinder Foundation for organizing this and inviting me. Amira, would you like to take over from there?
Yes, just briefly, thank you everybody. And as mentioned earlier, the Pathfinder Foundation intends to continue going forward with similar discussions with other countries as well, regional and international countries that have handled the pandemic, because it's a challenge that we all face, and we must all share our experiences and knowledge to overcome this together, so that all of us will be safe and protected and can look forward to a future, hopefully COVID-free. Thank you very much again. If you have any comments, please feel free to pose it to Pathfinder Foundation. But until such time, be safe and thank you. Have a good day.
Thank you very much.
Bye.
Thank you.
Thank you. Have a good day.
Good day. Bye.